Thank you, Professor Pandey. Thank you for including me in this session on dealing with complex strabismus. And I'll be talking on third nerve palsy. Different strokes. So we may have different presentations of third nerve palsy. And as you all know, it is a condition which is otherwise also a complex problem to manage. So what are the kinds of challenges that third nerve can throw? So I have no financial disclosures on any of the things that we'll be talking about. As we all know, third nerve palsy is something which will present to us in the form of patient having a ptosis, having an exodeviation because of the medial rectus underaction, elevation limitation, as well as depression limitation in abduction. And in addition, if we look, there will also be an involvement of the pupil. Mostly there will be anisocoria or mydriasis, but sometimes there may be pupil sparing third nerve palsies. And in congenital conditions, you may sometimes have an autonomic pupil. So what are the important considerations? As we said, third nerve supplies all the extraocular muscles except lateral rectus and superior oblique. So it is having a major role to play in the ocular motility. It also supplies LPS in addition, the levator palpebrae. It also supplies the internal muscles of sphincter and the ciliary muscles. So the involvement of accommodation and the pupillary reactions should never be missed when we are examining a third nerve. Then again, there can be a presentation differentiation in the basis of whether the third nerve nucleus is involved, or it's a fascicular involvement, or is it a problem in the orbit when the third nerve has superior and inferior division, and the involvement can differ because of that. And then, as we said, some of them may be having an ischemic mononeuropathies, which are sparing the pupils in 70% cases. It many a times may be partial or may have recovered partially when it presents to you. So you have to keep that in mind. And then in addition, there can be aberrant regenerations. It is like a situation in like many nerves are passing in a bundle, and after being a cut and then regeneration happens, there can be a very simple possibility of a miswiring or having different connections. So this is what happens in aberrant regenerations. But mind you, aberrant regenerations are also indicating that it is a trauma or some injury which is going to disturb the passage of fibers. Ischemic mononeuropathies are usually not going to have an aberrant regeneration. And then there may be associated neurological deficits which we have to take care of. Now here is an example of a ischemic right third nerve palsy. And if you see this individual who is 70 years old, he is having limitation of adduction, elevation and depression, and the eye is exotropic. He also has a ptosis of the right eye, and if you look carefully, there is no change in the pupillary size. So there is pupil is sparing in this case. So this immediately should raise our suspicion that is some ischemic problem, and we should then be looking forward to this. But mind you, 70% of ischemic mononeuropathies are pupil sparing. 30% can have involvement of pupil. So it doesn't work the other way. So if you have a pupil sparing, you have to keep in mind. And secondly, if there is a partial third nerve palsy, there may be a pupil sparing even if it is not ischemic. Because in that partial by itself means that it may have not involved the pupillary fibers. How do we manage these cases? So one is complete ocular motor diagnosis should be made. We should investigate for the cause. So whenever a paralytic strabismus comes to us, apart from examining the ocular motility, we should always look into the fundus to see any papilledema and also the fields, which will give us an indication of associated neurological problems. Then we have to investigate for the causes, which may be vascular ischemic. So hypertension, diabetes, coronary artery disease or CVA should be ruled out. So have a profile of this in a patient who is having as shown here. In a study done by us in AIIMS RP Center, we had seen that 60 cases of ischemic mononeuropathies, out of those, 25 had diabetes mellitus, 15 had hypertension, hypercholesterolemia may be there in 8, and lipid profile disturbance was there in 20 cases. We need to investigate these cases. And in addition, we should also do neurological evaluation whenever there is a pupillary involvement, all cases. If the pupil is spared, you should follow these cases and in 5 days' time call them back. If the pupil gets involved in 5 days, they may have to be investigated for imaging. So keep that in mind. Once we have established that there's nothing else to be done neurologically, or they are non-ischemic, then we have to see how do we manage. And regular follow-up is done 6 weekly. And then we see after 6 months or 9 months, if there is no natural recovery, then we may require to do surgical management. For ptosis, many a times, crutch glasses can be given to the patient if there is a severe ptosis. But otherwise, you may do a sling surgery to lift the lid. But mind you, there will be a risk of, because of poor bells and exposure keratopathy. So that should be kept in mind. In surgery, we are going to determine the fixating eye, which is going to determine the target deviation. We'll have some cases that we have dealt with. Now, this is case 1 in which there is a right eye third nerve palsy. The eye is moving up to the midline, just barely so. So we may get away by doing an R&R, or nowadays we may say recession and plication surgery. And this is what was done in this individual, who himself happens to be a doctor. So we did a post-op after the LR recession of 24 millimeters, a supramaximal recession of lateral rectus, and a medial rectus plication of 8 mm. And the advantage of doing plication in paralytic squint is this, that if we are not sacrificing the anti-segment supply. So we can always do vertical rectus if they are recovering and if we want to improve the adductions. This case 2 shows you that when the eye doesn't cross the midline, what can we do? And LR was not tight. So in such a case, we may do a LR split transposition to medial rectus. So it's a nasal transposition of split lateral rectus. This has yielded very good results, and this can be done in such cases to improve the exotropia situation and improve adduction to some extent. Some cases may also have significant vertical deviation, and these cases, what we may do is horizontal deviation correction by the split lateral rectus to MR, like in this case. And in addition, the vertical deviation is taken care of by doing the vertical muscle surgery in the other eye, the contralateral eye. So here 2 muscles we have taken care of in the involved eye, then the verticals we can handle in the other eye to balance the vertical tropia. Like in this case, and after doing the superior rectus recession in the other eye, the left eye, you can see that the improvement of ptosis also is there. The pseudoptosis component has got corrected. Now, this case 4 shows that if there is a tight lateral rectus, what do we do? If there is a very tight lateral rectus, you cannot do a lateral rectus nasal transposition. And in such a situation, either a supramaximal recession or a periosteal anchoring of the lateral rectus is done. So in this case, periosteal anchoring of lateral rectus was done. And to improve the adduction, we have also done a medial rectus plication or resection. In this case, resection was done. When there are very tight lateral rectus of exodeviation up to 90 prisms, in such situations, a medial periosteal anchoring of the globe can be done to salvage the eye in the midline. And this is what is another procedure which is possible to handle such large deviations. And you can approach the muscles in this case through the precaruncular approach. Aberrant regenerations, as I said, we may have to tackle. And these are special situations. And what we need to do is look for what is the aberrant regeneration. In situations when the lid gets corrected or lifted up because of the abduction effort, we can do a contralateral LR-MR surgery. And as you see here, the left eye was involved, the right eye lateral rectus recession and MR resection has been done, and this has lifted the ptosis because of the aberrant innervation being used. This is another case in which you can see the left eye in which there is a ptosis and the right eye surgery has been done, and you can see the improvement in the ptosis along with the deviations being corrected. The case 7 shows you the acquired partial third nerve palsy. That means there is only the inferior division which is involved in this case, and such a situation, you can see the superior rectus is free and the lateral rectus is also not involved because it's a third nerve. So you do an FDT to see whether the LR and SR are not very tight. And in this case, I chose to do a modified inverse NAP procedure. And here what we are doing is NAP procedure for depression. That's why it's inverse NAPs, and it's modified by the virtue that we have taken the medial rectus, resected 6 millimeters and reinserted at IR, and the lateral rectus has not been recessed, just inserted at the right inferior rectus side. And as you can see, the post-op results has given considerable improvement in depression in abduction, as well as the exotropia has also got corrected. Another case in which we have a residual third nerve palsy with marked lateral incompetence. Now this was a residual third nerve palsy in which surgery has been done earlier previously. A lateral rectus recession at 12 millimeters was done with the medial rectus plication 6 mm. So what we have done in this is that we wanted to set it right in the incompetence, and I chose to do a Scott procedure on the left lateral rectus, and here resection of 6 mm and the recession on the same muscle. Mind you, it is the resection and recession on the same muscle that is known as the Scott procedure, and this improves the abduction incompetence much effectively. The last case which I would like to show is a re-surgery. So this individual had been operated elsewhere twice and he was still unhappy because of the large exotropia. So what I did was explore the lateral rectus and then recessed it 25 millimeters, that is 7 millimeters hang back, 18 millimeters on the sclera, and inferior rectus belly transfer to medial rectus, which again does not compromise the blood circulation. And you can see that the eyes have been straightened and there is an improvement in adduction. So important points to remember are deviation in primary position and other gazes should be noted. Fixing eye to determine the target deviation. Look for incompetence. Realistic goals should be set. We should counsel the patient because all the gazes cannot be improved in most of the individuals. Individualize the treatment. FDT for lateral rectus should be done, and if it is very tight, supramaximal recessions or even periosteal fixations may be done. If it is not very tight, then split LR to MR can be done. An option for the contralateral muscle surgery should also be kept in mind if there is an aberrant regeneration. So we have to be a squintellectual and we can have very good results if treated properly. Thank you all for a patient listening.
Thank you, Dr. Pradeep, for very informative talk. Only thing I wanted to ask you one thing. Well, you're doing periosteal fixation in some of these cases, and you cannot transpose vertical recti because they may have no force. So the abduction is going to be quite limited. There will hardly be any abduction, and that will create problems when the person looks in that gaze, particularly. Okay. So I think third nerve palsies are a very complicated situation because 4 muscles are involved. So one has to make a compromise and see how best to put the situation across.
Correct. So I think we need to counsel the patient. Most of the time we are interested, first is to improve the primary position. Second is to improve the primary and down. These are the two important gazes for us so that binocularity can be achieved. The rest the patient can have a head turn and manage. So the lateral deviations are going to be affected whenever we are doing a procedure like periosteal fixation, lateral rectus periosteal fixation, or a medial anchoring of the globe. Both ways there will be a lateral abduction. Even in the lateral rectus transposed to the medial side, we are again taking away the lateral rectus force altogether. So we do have, but they are still very happy patients because the primary position is something which they, and many a times they can learn to move their head, and most people cannot know that they have any problem.
That is true. It's a very difficult situation. So I think whatever they gain, they are quite happy.
Even so that's why counseling is important. You need to pre-counsel these patients what is expected from you and what can be done.
Yeah. So and one thing more, I think about torsion we should keep in mind because the fourth nerve is the only one left at times. So if there could be some little, if there is torsion, that also needs to be
if the torsion is there, then you should touch the superior oblique. You may have noted that I have stopped doing superior oblique transposition for third nerve palsies. I think 15-20 years back, following Dr. Prem Prakash's time, there was, in those days, the procedure described was superior oblique transposition. Superior oblique was used to adduct the force. But in such a situation, you will see that there will be severe compromising movements because the superior oblique is supposed to be lifting the eye in looking down. So it will give you weird movements at times. So that's why we have stopped doing the the superior oblique transposition, the Peters modification or the original.
That was, I think, initially described by Scott, I think.
Scott and Peters modification by cutting the superior oblique 20 millimeters and then removing from trochlea and then doing it.
And it went out of vogue slowly now.
So I think we have stopped doing that.
So third nerves are a very complicated situation and I think need someone like Professor Pradeep Sharma to handle them. All of us have done, but results can never be always 100%. So patient has to be counseled and told that he should not expect everything to be perfect for him like the other eye.
Thank you, Dr.
Thank you.